then we'll take the questions at the end. So I see that, that we've got quite a few attendees here right now, so I'll go ahead and get started with the introduction, so to be respectful of everyone's time. So thanks and welcome everyone. Today is our Global Health Colloquium for November, and the Colloquium represents a collaboration between the Colleges of Medicine, Nursing, and the School of Public Health, and represents our mutual interests in global health and advancing the field, both research and practice. And we meet every Wednesday of the first Wednesday of every month. And so if this is your first time joining us, then the next month will be for World AIDS Day, and that will be, the speaker is Jason Farley. But today we're very excited to have Dr. Vanessa Oddo here with us. And so Dr. Oddo is relatively new to UIC. She joined, I believe, just when the pandemic hit. And so we've finally been able to meet in person. So I've been excited about that. But Dr. Oddo is an obesity epidemiologist and an assistant professor in the Department of Kinesiology and Nutrition. She completed her MPH at Tufts University, followed by a PhD in human nutrition at the Johns Hopkins Bloomberg School of Public Health. And she did a postdoctoral fellowship at the University of Washington School of Public Health. So in addition to having a very, just a very competitive pedigree, she's also been extremely productive in the few years since doing her education. Her research broadly focuses on the social determinants of nutrition-related health, and she's currently leading a prestigious NIH-funded career award investigating the extent to which low-quality employment is related to obesity in the United States. Dr. Oddo has experience investigating the nutrition transition in low and middle-income countries and studies the impact of nutrition policies. She has served as a consultant to both UNICEF and the World Bank, as reflects her expertise in these areas. Here at UIC, Dr. Oddo is currently the lead instructor for the obesity course and serves on the faculty senate. She has been the recipient of numerous school-level conference and society awards. So we're very pleased to learn about Dr. Oddo's work today in nutrition, and I will turn it over to you. And then at the end, we'll do questions and I'll help moderate that. So thank you.
Great, thanks for that very kind introduction. I will share my screen here. Okay, yeah, so thanks for that introduction, Supriya. I'm really pleased to be here today to talk about work that is actually a little bit of a side project. Like Supriya mentioned, I have been consulting for UNICEF for, I don't know, about 10 years now, give or take, largely focused on adolescent nutrition, which has become a key focus of UNICEF's programming, particularly in Indonesia. But for the last year and a half, give or take, I've been working with them on sort of implementing and I'll say evaluating, but the data is quite descriptive. Some of the mitigation strategies that UNICEF has implemented related to malnutrition amidst the COVID-19 pandemic. So just by way of background, traditionally when we think about nutrition in the global health context or low and middle income countries, we really think about the burden of undernutrition historically. But increasingly, there has been recognition that really we need to be thinking about the triple burden of malnutrition, which is the coexistence of undernutrition, overweight, and micronutrient deficiencies. And unfortunately, Southeast Asia and the Pacific region contain nearly half of the individuals worldwide that are experiencing this triple burden of malnutrition. This is due to an increase in overweight and obesity due to changes in diet and the increased consumption of unhealthy and processed foods, as well as a decrease in physical activity as countries are undergoing their nutrition transitions. But at the same time, undernutrition persists, as well as the burden of micronutrient deficiencies, and largely this is due to a high prevalence of iron deficiency anemia. And Indonesia is really sort of a prime example of the triple burden of malnutrition. 1 in 3 children in Indonesia under the age of 5 has stunting or low height for age. 1 in 10 children has wasting, which is low weight for height. But at the same time, 8% of children under 5 are overweight, and about 40% of children under 5 have anemia. We see larger burdens of overweight among adults in this setting, and this is very consistent with countries that are undergoing their nutrition transition, where we see overweight increases among adults first, and then the overweight increases among kids sort of come a few, a decade or two later. But this is paired with high prevalence of anemia among women in this context. And as I mentioned, my work with Indonesia really initially started with a focus on adolescent nutrition. And this is because, this population is pretty hard hit by the triple burden of malnutrition, and is, a pretty large segment of the population in Indonesia. So we're talking about 45 million adolescents in this context. So what does nutritional status among adolescents look like in Indonesia? So these are nationally representative data, and you can see in the graphs on the right-hand side that, stunting has declined while overweight has really increased. Again, paralleling trends that we're seeing in other low and middle income countries. But still about 30% of adolescents are stunted, 9% are underweight, about 16% are overweight and obese, and about 32%, or about a third, are experiencing anemia. And we know that this is a nutritionally vulnerable life stage. One of the reasons that UNICEF has really started to focus a lot more on adolescent nutrition is because it's widely recognized that both undernutrition and overweight are intergenerational, right? So we want to target adolescents in sort of a preconception stage to try to mitigate this intergenerational pattern of both underweight and overweight and micronutrient deficiencies. Adolescence also serves as a really important period to mitigate any growth failure that might occur early in life, sort of during those first 1,000 days. It's also when adolescents begin to acquire unhealthy eating and physical activity behaviors that do track throughout the life course. And adolescent mothers further face increased risks of mortality and adverse birth outcomes. And so, this has been a really strong focus of my work the last 10 years with UNICEF, and also in terms of their programming and surveillance. Certainly none of us are strangers to COVID, and Indonesia is no exception. This is a huge, population. Indonesia is the 4th largest country in the world with 270 million people. Estimates suggest there's about 4 million reported cases of COVID in Indonesia. I'm sure that's, an underestimate. And they experienced a second big wave of COVID just this past summer after Ramadan that forced additional lockdowns and school closures after sort of the initial lockdowns in the spring of 2020. There's also been a number of supply chain issues, again, not unlike what we've experienced in the US to some extent, but greater food shortages in Indonesia during COVID. And also, because of travel restrictions, provinces that have been experiencing surplus yields have not really been able to distribute those yields to other provinces. So, there's a lot of concern related to food shortages and food insecurity due to COVID. At the same time, unemployment has increased, with families experiencing loss of income, and only about, a third securing social assistance from the government as a result of becoming unemployed. So, it's certainly Indonesians are experiencing, or likely experiencing food insecurity, decreases in income, already paired with high prevalence of this triple burden of malnutrition. And there's widespread concern of, collateral damage of COVID-19, which includes not, certainly many disruptions, but, of concern. And what I'll be talking about today is related to nutrition programming disruptions. So, Ongoing surveillance among children and adolescents is really key to preventing increases in undernutrition and overweight. Iron folic acid distribution at schools is sort of a mainstay of the nutrition programming implemented in Indonesia, and this has been disrupted. Certainly school-based curriculums and school feeding programs are, again, a mainstay of nutrition programming, not just in low and middle income countries, here in the US as well. And so these have undoubtedly been disrupted, as well as counseling for pregnant and breastfeeding mothers because of social distancing restrictions. So UNICEF, has implemented a number of programs that I've, been working with them over the last year and a half to try to some extent to sort of maintain the nutrition lifeline during the COVID-19 pandemic. I'm just highlighting a few here. There are, certainly other ongoing efforts and synergies with, the Ministry of Health and things like that. But a few of sort of the programs that they've implemented to sort of maintain the nutrition lifeline during the pandemic include nutrition surveillance among adolescents, incorporating or using new technologies to deliver interventions digitally related to malnutrition screening and treatment. They've used a train-the-trainer approach to implement a family-led or caregiver-led malnutrition screening program. And then I'll conclude by talking about a school-based intervention that actually started before COVID, but I think sort of highlights some of the challenges in terms of continuing to deliver nutrition programming amidst the pandemic, when so much of the nutrition programming is delivered through schools. So the first program or sort of mitigation strategy that I've been working with UNICEF on is this ongoing nutrition surveillance among adolescents. As I mentioned, this is a very vulnerable group, and UNICEF is quite concerned that we'll see increases in undernutrition and overweight with students no longer in schools. So they tapped into an online survey system that they have been, they've had access to for many years, and were able to recruit about 4,300 adolescents in Indonesia in June and July of 2020 to take a survey on food insecurity, diet and physical activity behaviors, and iron and folic acid consumption, comparing pre to during COVID. And so they used WhatsApp and Facebook Messenger applications to, get about 4,300 adolescents to answer sort of these key questions that related to nutrition and physical activity. So just very briefly, some of the sample demographics. The students were about 17 years old on average. It was primarily the sample, about 60% were female, and 60% of the respondents were from Java Island, which is where the capital of Indonesia is, and it's a largely urban area. So definitely this sort of disproportionately surveyed adolescents in urban areas in the capital. And, certainly this is a convenient sample. It's not nationally representative or anything like that, but was, so I completely acknowledge the limitations of this data here. But what did diet behaviors look like sort of right after the lockdowns and the onset of the COVID-19 pandemic? About a quarter of the adolescents surveyed reported that they were experiencing hunger. About a third reported that they were eating fewer meals, and largely this had to do with lack of economic resources. So lack of money, prices of foods increased, or foods were not available. As I mentioned, there are a number of supply chain issues in Indonesia like we're experiencing here in the US. We also saw about 40% of adolescents reported less variety of foods consumed. And again, a lot of this had to do with financial resources. They didn't have the money to purchase a wider variety of foods, and also the prices of foods had increased. We were also able to look a bit at specific foods consumed during the pandemic. About 40% of the adolescents reported that they were eating meat less since COVID started. 33% reported they were consuming fewer fruits and vegetables. And these foods tend to be more expensive, so that sort of aligns with the sort of prior data. But at the same time, we did see also lower, self-reported consumption of sugary beverages and sweet and savory snacks, as well as about 82% of adolescents reporting that they were cooking at home. So, likely again due to lockdowns, but this sort of paralleled some other data from this survey, which suggested they, were procuring food less so at markets and street vendors, and also did have less exposure to unhealthful marketing, food marketing, because of the lockdowns and closing of restaurants and vendors and things like that. So, pretty expectedly, and I think probably similar in the US, 50% of adolescents reported that they were getting less physical activity during COVID compared to prior to the pandemic. And the weekly consumption of IFA, iron and folic acid supplementation, which is the primary intervention to prevent and treat anemia, was pretty abysmal. It was only 10% of the sample reported that they were consuming IFA on a weekly basis. And, to provide a bit of context, weekly IFA distribution at schools is a national program. So all school age going adolescents are supposed to receive this supplement at schools on a weekly basis. Now, of course, with school closures, one of the mitigation strategies by the government, with help from UNICEF, was that the IFA supplements were supposed to be delivered to adolescents' homes directly. But you can see here that only about 15% of those reporting they consumed IFA reported that the supplement was delivered to their house. And so, clearly, despite certainly the government and UNICEF's best effort to maintain this nutrition programming, despite school closures, I think, the regular consumption of IFA, based on this convenience sample, really fell off during COVID. So with, again, this is certainly just a convenience sample. It's not nationally representative or anything like that, but we did see a mix of negative and positive nutrition related behaviors based on this sample. The negative ones, I would say, potentially stand to increase the burden of undernutrition. About a quarter of the adolescents reported that they were hungry, and a third reported eating fewer meals. And this is, quite a bit higher than the reported prevalence of adolescents experiencing food insecurity in the same districts in 2017. The 33% consumed less variety of foods, signaling a possible decrease in diet diversity. And again, this sort of parallels what we think might happen, where they would stop consuming some of the more expensive foods like animal source proteins and fruits and vegetables. We saw lower physical activity and also lower consumption of iron and folic acid. On the positive, we did see generally lower consumption of energy dense foods and beverages. So this is great. And more cooking at home. Whether these will, continue beyond COVID-19 and the lockdowns is to be determined. So moving on now to talking about some of the interventions that UNICEF implemented to try to mitigate some of the disruptions to surveillance of malnutrition among children under the age of 5. The first was this chatbot digital intervention for malnutrition screening and treatments. And so again, just to provide some context about what was going on in Indonesia prior to COVID-19, certainly a mainstay of nutrition, treatment in Indonesia is sort of health center based treatment of wasting. And despite that being ongoing in Indonesia for several decades, the coverage is really pretty low. And in 2018 and 19, Indonesia, the Ministry of Health, with support from UNICEF, implemented a more community-based surveillance and treatment program where children were screened via mid upper arm circumference tapes, which I'll show a picture of in a few slides. and also by community health workers. And rather than sort of more health center based care for severely wasted children, they started to provide home-based care as it was appropriate. And so, there was pretty serious concern that without this ongoing surveillance and treatment in the community during COVID, that we might see pretty serious increases in wasting among children under 5. So one of the programs that UNICEF implemented was this chatbot online counseling and training related to wasting and screening among caregivers. So in March 2020, they enrolled just 41 parents in a pilot study in one province, which was one of Indonesia's poorest. Again, relying on technology. So they used this chatbot software to deliver the information to parents and caregivers through WhatsApp Messenger. And so all of us have probably sort of engaged with some kind of chatbot software. You might, text, I don't know, like to schedule an appointment, for example, you might text a number and then the chatbot responds to your inquiry for scheduling an appointment using AI technology. And so it's something very similar to this. And they were able to use chatbot software to provide information on wasting, give guidance on MUAC measurement, as well as ready-to-use therapeutic foods for children that were severely wasted in written, visual, and voice formats. So they provided pictures of how to do the MUAC measurements and videos on how to do it, as well as guidance on the treatment food that was provided. We assessed some pre-post knowledge in terms of effectiveness of the intervention. And again, this isn't a rigorous study design, but very descriptive pre-post knowledge test, as well as conducted semi-qualitative interviews to get the participants' perceptions of this this online counseling and training that they were provided. So these are some sample characteristics of the, just the 41 participants, the parents and caregivers in the pilot. About, on average, they were 30 years old, half were female, sort of a range of levels of education. And again, this is descriptive, but we did see increases in overall knowledge related to wasting, the signs and symptoms of wasting, MUAC measurement, and the RUTF, the ready-to-use therapeutic foods that they were, instructed on how to give their children them if appropriate. Quantitatively, a majority perceived the online training as excellent and generally found it useful or very useful. We also, as I mentioned, conducted semi-qualitative interviews, which I think elucidate a little bit more some of the participants' thoughts on the online training, or that really it's, sort of Android phone-based training, but they did perceive that the language was simple and pretty easily understandable. They did get a better sense of how to administer the RUTF, so more frequent meals, but smaller portions. They also learned that there was a specific food to treat severe wasting, as well as, there are a few people thought it might help overcome the sensitivity of the topic. So rather than, maybe engaging with a community health worker or even a doctor at a clinic, where there's some stigma around your child being wasted or undernourished, here they could access the information themselves and learn more about both monitoring their children via the MUAC tapes, but also potentially knowing that they needed to access a specific food to treat the severe wasting, sort of in the privacy of their own home or with their spouse. It seemed to also somewhat be sort of empowering, I think, to some of the participants. They felt this was good. They could, measure their own child's MUAC regularly and, kind of keep on top of things, as well as also potentially guide other mothers at the healthcare centers, as appropriate. Certainly there were challenges, digital literacy being the primary one. Some reported they did need additional guidance on accessing the chatbot. And of course, this required access to WhatsApp and an Android-based phone. Some reported that they weren't able to access the voice or video services when they had limited connectivity or limited data availability, but this is something that we would need to work on in sort of future rollouts. They should have been able to download the videos and the pictures and not have to reconnect to the internet to access the information every time. And so that's something that needed to be communicated more clearly in the training, certainly. Literacy was less commonly reported as a barrier, but there were a few participants that said they needed someone else to read the information despite the voice and video information provided. So moving on to the family-led malnutrition screening. So the sort of chatbot digital intervention, obviously it was a very small pilot of 41 parents and caregivers, but the family-led malnutrition screening program was really designed to target a large segment of the population using a train the trainer model to screen, like I said, a large number of children under 5 for wasting. So UNICEF launched this program in April 2020, right? Sort of as the pandemic was happening. And here they incorporated this in the same province as sort of the chatbot training, the sort of text and WhatsApp-based training. But here they had health workers train community health volunteers who trained parents and caregivers about how to use that MUAC tape, and then instructing caregivers to bring children to healthcare centers if their children had a red, yellow, or measurement on the tape, or were visibly thin. So they were able to train about 33,000 caregivers using this train the trainer model. The caregivers or parents only received one online or face-to-face training on screening the children. And because of COVID-19 and social distancing, limitations, there was very limited supervision of caregivers' activities after the training. So really they just got this one training and then they were sort of set off to measure their own children and screen their own children over a period of about 6 months. So again, there's a lot of limitations to this data. It's ecological, and we don't know some of the whys, but we do know that there were about 50,000 children under 5 in this district that were, potentially eligible for screening. And between the community health volunteers and the caregivers that were trained, about 60% of children were screened over a 6-month period. So the program was launched in April, and this includes screening numbers up and through like December 2020. And you can see here, that very preliminarily, the caregivers did increase the capacity for screening. So about 12,000 children were screened by caregivers. So, parents and caregivers screened their own children. And then, if, like I said, if they had a yellow or red measurement, they were instructed to go to the health post for health worker confirmation that the child was moderately or severely wasted. I think interestingly, caregivers who screened their own child as severe or moderately wasted were far more likely to bring the child to the health post for confirmation that they were in fact wasted. So we saw that about 86% of the kids that needed to go to the healthcare centers went if they were screened by caregivers, compared to only 27% of those children who were screened by community health workers. But I think importantly, one of the sort of big takeaways of this data were that the caregiver measurements were quite accurate. So they only received one training. There was really, very limited supervision of the caregivers doing the MUAC measurements. But as a whole, those that use a tape and determine that their child was severely wasted or moderately wasted were correct. And all the children that were confirmed severely wasted received treatment at the health centers. So some conclusions from this, I think, again, I completely recognize the limitations of this very descriptive data, but, both the chatbot screening, the training and the screening and the family-led screening seem to be complementary, feasible screening approaches beyond COVID-19. And certainly we don't know whether these programs, necessarily mitigated increases in malnutrition, but I think both seemed fairly promising approaches and helpful amidst the school closures and the social distancing lockdowns. I think interestingly, the family-led program, we noticed a larger proportion of children screened by the caregiver themselves attended the health centers as recommended. We don't know why this was. I mean, certainly maybe just more urgency and awareness among the caregivers themselves that, their child was wasted and needed to seek treatment potentially. It's certainly possible there were challenges to accessing the health posts for some. And, of course, possible that there was fear in terms of bringing the child to the healthcare center that they might contract COVID. And again, this data is very descriptive and preliminary, but it is consistent with, I would say, more rigorous studies from sub-Saharan Africa that suggest that caregiver measurements are, they do tend to be pretty accurate. And, this is definitely a screening approach that I think warrants consideration beyond COVID-19. So finally, I'm just going to take about 10 more minutes to talk about a school-based intervention that wasn't specifically implemented to sort of mitigate, the COVID-19 disruptions necessarily, but I think speaks to some of the disruptions in nutrition programming that are ongoing in Indonesia and certainly in other low and middle income countries. So this was a pilot that was implemented as a result of, like I said, several years of work focusing on, improving the nutritional status of adolescents. So in Indonesia specifically. And so it was really, the framework was is focused on breaking the intergenerational cycle of malnutrition. A number of prior literature reviews suggest that there needs to be a package of interventions, and I'll talk about the 3 that were incorporated in the next slide. Again, this was a pilot with the hope that it would be successful and potentially scaled up in other districts and in other schools in Indonesia. We were able to recruit students, 540 students at baseline in 2 districts in Indonesia, and we retained the same 514 of this, the same students over, roughly the year or a little bit more than a year of the intervention being incorporated in 60 schools. This is just a pre-post design, but it is the same students over time, but there is no control group. So I think, certainly there are limitations to what we can conclude from this pilot study, but baseline data occurred in the spring of 2019. As I mentioned, there were widespread school closures amidst the pandemic, and then end-line data collection occurred during COVID in the fall of 2020. So there were 3 main intervention components. There was the school-based weekly IFA supplementation that I've mentioned a few times, that this is really a mainstay of adolescent nutrition programming in Indonesia. And UNICEF continued to support this, making sure that the IF supplements were delivered weekly at school and consumed together with breakfast that was provided. There was also a school-based nutrition education program that got incorporated into the curriculum at school. And again, UNICEF implemented a train the trainer model, where they, trained school health teams on the learning modules, and then the curriculum was delivered in schools for 30 minutes a week for 36 weeks. And then there was a school-based social behavior change component, an SBCC messaging campaign about, the importance of controlling and preventing anemia by taking IFA supplements, healthy dietary practices, and physical activity. And, the primary indicator for the intervention was to increase knowledge related to nutrition, physical activity, and anemia, with the hope that there would also be some changes in behavior, so diet practices, physical activity, and again, the IFA consumption. So here we did have, sort of a bit more robust methods in terms of the questions asked and the statistical methods used. We asked multiple choice questions related to the information delivered during the interventions, questions related to healthy eating, physical activity, and anemia. And there was, a battery of student questionnaires related to demographic information. We had 24-hour dietary recall and FFQ data, self-reported physical activity, and weekly IFA consumption data as well. And did use multivariable linear and logistic regression to test for pre-post intervention differences with school level clustered standard errors. So these were the characteristics of the sample. Kids were 15 years old on average at endline, about half were female. About 20% of the adolescents resided in a low socioeconomic status household. And as you can see, pretty much all of the adolescents reported using social media at the endline data collection point. We did see that the intervention, increased knowledge related to healthy eating, physical activity, and anemia. Overall, comparing baseline to endline, we saw a statistically significant increase in the overall score. So this was the knowledge questions we asked that were multiple choice, and then increases in knowledge related to healthy eating, physical activity, and anemia. I would say, we saw more modest changes in behavior. Certainly, I think, we know that increased knowledge doesn't necessarily result in behavior change. But nevertheless, we didn't see changes in overall diet diversity, but we did see a higher odds of consuming vitamin A rich fruits and vegetables at the, comparing baseline to endline. And kind of paralleling the earlier adolescent survey that I mentioned, we did see pretty dramatic decreases in the consumption of sugary beverages and snacks. Of course, this, as I mentioned, this data was collected during COVID, post lockdown. They were in school, but still, potentially some of these decreases of sort of unhealthful foods are sort of a result of just sort of ongoing challenges related to COVID and closures and things like that. We did see the adolescents self-reported a higher odds of meeting physical activity guidelines, 60 minutes a day for the prior 7 days, and an increased odds in adolescents reported that they had ever taken iron folic acid tablets at school. So there were a number of sort of COVID-related pivots during this intervention. And this is sort of why I'm talking about this, to sort of think through some of the disruptions to nutrition programming, because so much are delivered in schools. The intervention was halted for several months during the pandemic. There were difficulties in continuing the curriculum development and implementation during COVID-19. And, as I sort of alluded to in the other survey, the regular delivery of iron folic acid tablets at schools was very challenging. Certainly there were reports of adolescents dropping out of school or really basically not returning to school after the school closures. And just from like the research standpoint, the data collection method needed to shift because of social distancing requirements. So basically most of the data was collected online at the end line time point. But, some very preliminary conclusions from this sort of pre-post intervention, we did see, that at baseline the baseline data suggested there was potential to improve knowledge. I, didn't talk about each of these points, but, at baseline, there was a really energy dense foods were widely consumed. Only 24% of students participated in daily physical activity. And this is very consistent with prior studies suggesting that, adolescents in Indonesia are sort of experiencing their nutrition transition. Comparing pre-post, we did see higher knowledge when comparing, like I said, pre to post intervention, and some improvement in terms of physical activity and IFA supplementation behaviors. But I would call the effect of the intervention on diet to be quite modest. We did see a decline in the consumption of unhealthy foods, but it still was pretty high. And it's likely some of this decrease was really the result of widespread lockdowns, and whether this will continue sort of post-COVID is unclear. So I think, these sort of declines in unhealthful food consumption are certainly going in the right direction and ideal, but we'll have to continue to monitor these kinds of behaviors in this population. So just some overall concluding thoughts, and then I'm happy to take any questions you might have. I think certainly, there have been definite disruptions to nutrition surveillance and programming that stand to increase the triple burden of malnutrition in Indonesia, but elsewhere as well. And these data don't elucidate the full extent to which school closings and this disruption in surveillance affected nutritional status yet. But I think this is something that we're going to have to closely monitor, and certainly UNICEF and the Ministry of Health have done their best to mitigate some of these, potential, the potential collateral damage of disruptions to nutrition programming. But I think we'll have to continue to monitor this closely. There probably are some positive nutrition behaviors to reducing the consumption of energy dense foods during COVID, and we'll have to see if these continue, as I don't know if I don't want to say if we get back to normal, but if adolescents kind of return to pre-COVID behaviors related to food procurement at kiosks and corner stores and those kinds of things in this setting. But I think an additional takeaway from the last year and a half is certainly we have seen a shift towards a reliance on technology, both for research, but also for intervention delivery and the training delivery that UNICEF implemented because of COVID and social distancing. And there may, I think this might be a useful pivot for the future in terms of complementing more traditional screening, nutrition surveillance and treatment. And so I think that's something that UNICEF is certainly thinking about in terms of, continuing to offer some of these online trainings and sort of caregiver-led screening approaches to complement sort of the more traditional programming that they've implemented for the last decade or so. And so with that, I will take any questions that folks might have. I see maybe there's a few in the Q&A, but happy to take any questions.
So thanks, Vanessa. That was great. It's just to see the breadth of the effect of the pandemic in every aspect of life, and thinking about the lasting effects that's going to have. So there are a few questions in the Q&A that I'll start with, and because one of those aligns with one of my questions. So this is from Mari, and she asked, can Dr. Oddo speak to any community-based nutrition programs for adolescents outside of the pandemic? And so I think you did start on that, but to reach adolescents not in school, And then she had a second question about, she was interested in any gender dynamics and food distribution in this context. And so I have a related question to that, so I'll add it. I did notice at the beginning, you showed those graphs stratified by sex, where it showed that boys had an increasing rate of overweight, obese, greater than girls, but they also had higher rates of stunting. So I think that that's in keeping with Mari's question on the gender dynamics in the food distribution. But so if you could speak to those two things, I don't know if you have anything to add to what you've already talked about with the adolescents, and nutrition outside of the pandemic. And yeah.
So related to sort of the gender and dynamics of food distribution and just like the differences in prevalence of stunting and overweight and obesity. I mean, certainly, and I think this is true beyond just adolescents, but yes, I mean, definitely in many of the surveys that UNICEF and that I've worked with them on over like the past decade, we do definitely see differences in, the amount of food consumed by adolescent boys versus girls, and also the kinds of foods. I mean, probably somewhat paralleling things we might see here where, boys do tend to be larger consumers of like the unhealthful foods, sugary beverages and things like that. And girls tend to, I would say, like, at least in this context, eat a bit healthier. And that's probably one of the reasons that we do see increases in overweight and obesity, or larger prevalence of overweight and obesity among boys. Although at the same time, they're certainly more physically active in a lot of these surveys. And so really, like, anything that UNICEF does in terms of like interventions or surveillance is always like gender responsive, and like the data are always gender stratified, because, certainly I think there are differences in terms of food distribution, in terms of physical activity, in terms of iron folic acid distribution and consumption between boys and girls in this setting. So I didn't get into like all the gender stratified data and stuff, but the intervention, the last sort of set of data and slides, I didn't get into this too much, but like all of the curriculum and the SBCC pieces were designed to be like gender responsive and specific. So boys were kind of given a certain set of messages and girls were given a different set of messages. Like, you can be physically active. Like, it's okay to, it doesn't have to be sport. You can just take walks, for example. Like, that was one of the messages delivered towards girls. Sorry, I think I forgot what the first question was.
Just if there were other, and I think, she posted the question before, but about, certainly. So I'll say that there have been so I would say yes, that non-school going adolescents, boys and girls, are kind of a bit of a missed population, and it is of concern. The large majority of programming in Indonesia, but this is true in most low and middle income countries, are delivered in schools for the obvious reason that it's an easy way to target adolescents. More so, they're trying to incorporate some of this stuff like iron folic acid supplementation in like healthcare centers. So like if an adolescent girl who's non-school going, potentially she's married, say, if she visits like a health center for whatever reason, like they'll, talk to her about weekly iron folic acid supplementation. But it is a challenge, and the primary delivery platform in Indonesia and probably most low and middle income countries is schools. So it's definitely like an area that needs more work. And I would say, it's something that UNICEF recognizes, certainly, but also just sort of a limitation of resources and where the resources are going to reach the most adolescents in this setting. Thank you. There's another question in the box from Gracia. Thank you for the great presentation. I think these are all good initial programs to be implemented in Indonesia, as long as it accounts for all factors socioecologically, individual, family, community, structural. What is your opinion regarding the sustainability of the programs? meaning funding, acceptability, etc. Sorry.
Yeah. I think at least as far as like the sort of like digital, the things that are like digitally delivered are, you know, fairly sustainable. I mean, yes, like there are some there are some like costs with UNICEF initially sort of delivering the trainings and things like that. But I think, you know, as compared to other interventions, it's a fairly sustainable approach. I think the family-led, you know, certainly, yes, like I to your point about like differences in terms of like socio-ecological, you know, like households at different income levels. Yeah, I mean, I certainly think something that's like digitally delivered might not reach the poorest of households. And that said, I mean, even in this context, a large majority of households have at least one mobile phone at this point. And so again, like I think it's reasonably, I think we can assume that we can reasonably target most people. But then at the same time, you know, like having the sort of complementary train the trainer, healthcare workers train the sort of local people, I think is a way to sort of supplement the sort of digital technologies. So, you know, I certainly think that, you know, UNICEF and sort of the Ministry of Health, when they're thinking about these programs to mitigate the effects of COVID or nutrition programming in general, consider these things. But I would say like the large majority of households have at least one mobile phone, and they do, I would say, try to deliver programs at multiple, you know, via multiple delivery platforms to hopefully try and reach the most people. So cell phones, schools, healthcare centers, community volunteer, you know, community health workers, to try to reach the most people.
All right, thank you. We have another question from John Ziegler. You indicated involvement of community health workers. Are there any opportunities for youth leaders?
Yes, that wasn't something that they specifically like engaged with for this particular intervention, but in prior, like in other interventions that I've worked on with UNICEF, specifically targeting adolescents, one of the components, again, is like training the youth like within the schools to be sort of champions of the curriculum and engaging their fellow peers in physical activity and things like that. So that wasn't something implemented in these interventions specifically, but it is something that I think UNICEF recognizes as an important component of interventions that target adolescents, and in other again, like school-based interventions, they have incorporated like a train the trainer kind of thing where they train the youth and then the youth kind of deliver some of the messaging.
All right, thank you. We have another question from Putri. Thank you, Dr. Oddo, for sharing the great work. I am Putri, an MPH student in UIC from Indonesia. Remembering that in the poorest provinces, some areas have very low access to health facilities, I am curious if there is any further intervention plan to reach this community, especially for the follow-up after the family-led children nutrition surveillance. Thank you.
Yeah, so that's a great point. And I kind of alluded to this in, so again, we don't know why certain people like brought their kids to the health centers versus the others for when they were screened as wasted, but certainly we speculate that, you know, there were distance challenges for some. And so, you know, I think in non-COVID times, the community health volunteers do, you know, go out to the communities to reach these populations, and that, you know, just wasn't as possible, you know, during COVID, both because of the social distancing, but also like honestly, the community health workers didn't want to be going out, they were concerned about their own health and well-being and trying to go to, interact with people. So I don't know of if UNICEF is like specifically following up with how to reach like those like children who say were screened as wasted but didn't ever attend the health centers. But it is a recognized challenge, and I think during non-COVID times, they would then do like more direct outreach from, have community health workers go out, again and follow up. And I just don't know that was like really feasible during COVID for a variety of reasons. So, I mean, certainly I think these are the kinds of sort of issues with COVID and continuing to implement the various surveillance and programming that, do unfortunately, are cause for concerns in terms of increasing malnutrition.
Thank you for those answers. We are almost at time. So, if there are any burning questions, please put them in the chat box or in the Q&A session. And yeah, just so amazed by, everything that's been touched by this pandemic, and that hopefully these impacts on nutrition are not, lifelong, that they'll revert once everything becomes more available, so that we don't have this forever. Because as you said, it's not just Indonesia, it's so many other countries that are in a similar situation. So
yeah, I agree. I think, definitely World Bank and UNICEF and all of these organizations are really thinking hard about how to try to mitigate these disruptions and hopefully not be like long-term consequences of COVID on nutrition. So we will see.
All right. Well, thank you everyone for attending. We hope to see everyone again in December for World AIDS Day. And hopefully you'll reach out to Dr. Oddo with any additional questions that weren't answered here. So thank you so much, Vanessa, for your time and for your presentation today. This was great. Thanks, everyone.
Thanks so much for having me.